All right. Thank you everyone for joining this week's seminar. Today we're going to go over a case study, and then we're going to go over a disease, vitreomacular traction syndrome, and then we're going to do a couple interactive medical dilemma situations, and then we're going to do epilepsy. Unfortunately, the guest speaker today was cancelled, like the guest speaker event, so we won't be doing that today, but we do have a range of different things we will be touching over, so I hope you stick around. Can I have Neha for this, please?
Hello everyone. My name is Neha, and today I'm going to be going through this case study, which is Jesse Gelsinger's 1999 case of the first death in gene therapy trial. So, first of all, what is a gene therapy trial? A gene therapy trial aims to treat or cure a disease by correcting a faulty gene, replacing it with a healthy one, or adding a new one. These research studies involve introducing modified genes into the body, often using viral vectors, which are modified viruses used to deliver genetic material into the cells. And these trials are conducted in phases to evaluate the therapy's potential risks and benefits in a controlled environment. Gelsinger had OTC deficiency, which is a rare X-linked genetic disorder that causes a deficiency of the OTC enzyme. This leads to an excess buildup of toxic ammonia in the blood because the body cannot properly process waste from protein breakdown. This metabolic disorder affects 1 in 40,000 newborns. However, Gelsinger had partial OTC deficiency, which he kept in check with a low protein diet and drugs. At this point, he was considered an ideal candidate for the gene therapy trial, led by Dr. James Wilson, who was the director of the Institute for Human Gene Therapy at the University of sorry, I can't say that word, Pennsylvania. Um, so what happened during the trial? Gelsinger was given an infusion of corrective OTC gene encased in a recombinant adenoviral vector, which was injected into his hepatic artery. Unfortunately, Gelsinger experienced a severe immune reaction to the vector and died 4 days after receiving the injection. So what happened after? The FDA halted the rest of the university's human gene therapy trials and investigated 69 other gene therapy trials. 28 trials were reviewed, with 13 requiring remedial action. The FDA and National Institute of Health also introduced two new programs: the Gene Therapy Clinical Trial Monitoring Plan and the Gene Transfer Safety Symposia. The gene therapy clinical trial monitoring plan requires disclosure and clinical monitoring before a trial begins and clarifies what events need to be reported. The gene transfer safety symposia allow researchers to share data and clinical experience, particularly regarding adverse events. Numerous ethical issues emerged from this case. First of all, we had the matter of informed consent. According to his family's lawyer, Gelsinger was not told that several other patients had serious side effects from the same therapy, or that 3 monkeys had died of clotting disorder and severe liver inflammation after the injection. Informed consent is a very important part when it comes to patient and doctor interactions, as it allows patients to make voluntarily well-informed choices about the care or about the trials they decide to participate in. Another ethical question that was raised was whether relatively healthy adult volunteers with OTC, like Gelsinger, should have been used as subjects. At first, it was suggested that newborns with OTC should be experimented on with the parents' informed consent, since they were already very sick. But then, would the parents truly understand the risks and be aware that these trials may not even help their baby? In contrast, adults can understand the risks and weigh them against the benefits, providing informed consent. Would you make the same decision if you had to choose who to test your trials on? Then there was the issue of a conflict of interest. The lead scientist, Dr. James Wilson, had a financial interest in the development of adenovirus vector being used in the OTC gene therapy trial. If this trial was successful, he could make a lot of money by selling it to researchers or using it as patient treatment. This conflict of interest may very well have influenced the decisions made by Dr. Wilson. So, could he really have made a sound decision about an experiment knowing what was at stake? Thank you for listening to this presentation. I hope you were able to understand more about this case and how ethical issues can arise surrounding gene therapy trials.
Thank you so much, Neha. This is obviously a really important case because it talks about informed consent, and that is a really big part of like the NHS guidelines. You do need to talk to patients about what might happen if they take the treatment or they don't. And so Gelsinger's case was missing that, and that's why he had to suffer such severe autoimmune, problems. But yeah, that's a really good, insightful case study. But now I'll hand over to Ahmed for vitreomacular traction syndrome, please.
Hi, I'm Ahmed, and I'm going to be talking to you about vitreomacular traction syndrome and what it is and how it's treated. Could you move on to the next slide, please? Thank you. So, what is VTM? Vitreomacular traction. Sorry, that should say VMT. VMT is the correct acronym. So, it's related to the vitreous humor, which is a gel-like substance that fills the central cavity in your eye because a lot of your eye is filled with fluid past the initial membranes. So it occurs when that vitreous humor remains attached to the macula more than it should be. So that's after it's already pulled away from the retina, causing your vision to distort and other complications related to the macula because the membrane isn't in the correct shape that it should be. So this pulling force can lead to the macular swelling, and it could also lead to the formation of cysts or holes in the macula due to ripping because of this stretching, which causes significant vision loss if it's left untreated because of the holes. So, what are the symptoms of VMT and why is it dangerous? So, in most cases, like many cases actually, the VMT is fine, it's mild, and it doesn't really need much treatment. But in other cases, if it does end up becoming severe, then it can cause blurry vision, seeing flashes of light, objects looking smaller than they are, and distorted vision again due to the ripping and the abnormal shape of the macula. So, what are the risks of VMT? What risk factors, sorry. So, risk factors such as increasing age. Increasing age leads to the breakdown of the vitreous membrane over time. This is a natural process which forms fluid in the vitreous cavity, causing the vitreous to pull away and shrink, leading to VMT. Then there's nearsightedness, which also again increases the risk of early vitreous syneresis. And certain eye conditions, such as diabetic retinopathy, it can also increase the risk of VMT. So how is it diagnosed? So the first step, like any other disease, is patient's history. After that, there's a couple of different things that can be done. One of them is an ophthalmic examination, which can show distortions in the retina or elevations in the macula, which would suggest to a doctor that VMT is what the patient is diseased with. Or the gold standard, which is the OCT exam, which is the optical coherence tomography, which provides high resolution images of the cross sections. And that is the side image of the eye of the vitreoretinal interface. So a positive result for this would show partial detachment. Again, that's because it's not detaching fully from the vitreous membrane at the posterior side. Then adhesion of the vitreomacular membrane because it's sticking to the macula, or muscle thickening or early macular hole formation. So the muscle thickening is again due to the sticking, and early hole formation again due to the ripping of the macula. So what are the treatment options? So the image you'll see on the left here, that is an image of the surgical procedure. So first, the usual one is just a watchful eye. So doctors keep on watching the eye, looking at the symptoms and like keeping regular checkups with the patient to see if these s- sorry, to see if they actually need any active intervention. So active intervention would could look like this, vitrectomy surgery, where a procedure where the vitreous like gel-like substance is cut through and removed and replaced with saline solution, which you might have heard of before, a gas bubble or silicone oil to address issues like retinal detachment, so prevent it sticking or not sticking at all, or bleeding as well due to the rupture of the membrane. And then it could also be from pneumatic release, which is again another procedure where a small gas bubble is injected into the eye, causing this rarely, sorry, causes a loss of vision, and it has a success rate of 80%, which is slightly higher than the vitrectomy surgery at around 60%, I think. Thank you very much.
Thank you very much, Ahmed. Now we'll just go on to a couple situations that you might experience with as like a doctor, as a surgeon. So yeah, let's get started. So situation one. So NICE guidelines recommend a specific biological therapy for a patient with rheumatoid arthritis. So that is like an autoimmune disease, particularly affecting joints, that would significantly improve their quality of life. However, your local clinical commissioning group has not approved funding for this drug, citing budget constraints or and they're requesting you to try cheaper alternatives first. So what would you do? I'll just give you a couple moments to think about the answer, and please put them in the chat. So CCG again is local clinical commissioning groups. And as I talked about previously in one of our previous webinars, we talked about the structure of the NHS. And so the CCG does the funding for your local area, so your local like healthcare centers or your mental health centers or GP practices, dental practices. So they handle all of that. So they handle the funding. And obviously rheumatoid arthritis, it's the autoimmune disease. So yeah, what would you do? Okay, a couple answers are popping up, and the answers that I saw, there were two. I saw C, which is apply for individual funding. So yeah, the answer is C, and that is because according to the NHS funding and NICE guidelines, approved treatments from NICE, they should normally be available in the NHS. So clinical commissioning groups cannot blanketly like refuse NICE approved treatments without individual consideration. And so individual funding requests, which are IFRs, and so as a medic, you would try and file for that. These are like requests that will allow exceptions for clinical need, and you need to document why cheaper alternatives are inappropriate for the patient, so specifically for the patient. Um, and then the patient also has a right to receive NICE approved treatments when clinically indicated, because if you remember to the webinar when we discussed about the seven guiding NHS principles, it says that you need to provide the best quality care that is possible. So the clinical commissioning group doesn't really have a say in the NHS guidelines. So, they do have a right to approve the treatments. Um, and yeah, if the IFR is refused, then you should consider involving patient advocacy services, which are basically they're going to help the patient decide what they can do in terms of legal legal actions and what they can do about like for informed consent. So if you go back to Gelsinger's case, we saw that he wasn't given informed consent. So this is where it would be important. Situation two, during a routine consultation, an elderly patient mentions that their adult child has been taking their pension money, and sometimes the child gets agitated when they ask for it back. And so the patient begs you not to tell anyone, saying it will only make things worse. So here are four situations, and please pick one. And if you could give like explanation of why, that'd be helpful too. Okay, I'm seeing a couple C's and D's. Ahmed said D, it is in the patient's best interest to be provided support while you fulfill your duty of confidentiality. Um, so yeah, the answer is D. The NHS safeguarding adult procedures, they mention that adults have the right to make choices, even if they appear somewhat unwise. And but you can't override confidentiality without consent, unless like there are like exceptional circumstances where, a patient might be in actual like really, really, dangerous situations. You must provide information about available support and protection. So again, referring back to the idea of informed consent to the patient. And you should encourage self-referral to the patient to adult social care so then they can deal, with the problem. But then you're not breaching confidentiality. And consider if the patient has capacity to make these decisions, and only breach confidentiality if risk of like serious harm and person lacks capacity or they can't protect themselves. But you do need to document these discussions and reasonings very thoroughly. Okay. Situation three. A patient develops severe complications after routine surgery due to a delay in recognizing post-operative bleeding. So the delay occurred because nursing staff were busy with other patients, and the surgical team didn't respond quickly to concerns. The patient survived, but required additional surgery and prolonged hospital stay. What will you do? So, would you investigate quietly? Would you inform the patient about the delay and its like contribution to complications, or would you wait to see if the patient questions about what happened? Or would you discuss only with the patient's family, not the patient directly? Okay, it is your duty to keep the patient informed as the medical staff. So people are saying B, and yes, the answer is B. So according to NHS duty of candor requirements, the legal duty, like medics have legal duty to be open and honest when things go wrong. Again, when you refer back to the NHS guiding principles, there was one principle where it said that the NHS needs to be honest to the public. So this is where it kind of comes in. You could kind of link that together, but at a much smaller scale because you're not, the whole of the NHS, you're just a medic. You must inform patient or family if like appropriate, if the patient, hasn't woken up yet. So you could talk about this to the family as soon as reasonably practicable. And you need to provide truthful information about what happened, so any mishaps that occurred, and you need to apologize for the inconveniences caused. You need to offer appropriate support and remedial action because you need to, treat the patient and the harm that was caused. You need to document all communications about this incident thoroughly and very like detailed. It needs to be very detailed. And this applies when moderate or severe harm occurs due to the care provided. Okay, last situation before we move on to epilepsy. You have two patients needing hip replacement surgery. And so patient A has been waiting for 16 months and is approaching the 18-week referral to treatment limit. And patient B has waited 8 months but has significantly more severe symptoms and functional impairment. You have only one theater slot available this week. So what will you do? Will you prioritize patient A? Would you prioritize patient B? Would you cancel the slot and reschedule both patients together? Or would you refer patient B privately to avoid the dilemma? Again, referral to treatment is like an NHS guiding principle. And so that is basically waiting times, waiting lists. Okay, I have one answer in the chat. So B, because it does least harm. So Ahmed has the logic of because patient B is is experiencing significantly more severe symptoms, they should be prioritized because they have like more adverse health effects. Again, Ellie is also saying, I feel like the patient with more severe symptoms should be prioritized. And yes, that is true. So the NHS clinical prioritization principles suggest that clinical need must take priority over administrative targets such as the RTT. Waiting times should be managed according to clinical priority. So for to actually prioritize surgical, procedures, you should use a validating scoring system like P1, P4 categories, and you should document clinical reasoning for prioritization decisions. So why you chose another patient over like another patient. And you should ensure that both patients are appropriately informed about waiting times, and you should work with management to address systemic capacity issues. And referral to treatment targets are important, but they cannot override clinical judgment and what the condition of a patient is like. So here we have like a P1, P4 graph, and basically it just lists patients with urgency and impact. And so this will help you prioritize the patients that need more clinical attention because it is quite hard to decide. All right, now I'll hand over to Silver, one of our well-being officers, to do epilepsy, please.
Okay, so epilepsy. So one thing about epilepsy is that it mainly targets the brain and can affect a lot of different regions. For example, the frontal lobe. So what is the frontal lobe? It's the largest lobe in the brain, and it's located at the front. It's responsible for personality, decision making, and also movement. It contains the Broca's area, which is associated with speech ability. If you were to damage the Broca's area, you'd get a lot of issues with your speech development and how you sound when you're speaking. We also have the parietal lobe. This is the middle region of the brain. This receives and interprets signals from other parts of the brain. and can also interpret visuals, hearing, motor, sensory, and memory aids, and also aids with understanding in terms of objects and spatial awareness, and also to interpret pain and touch. You have the occipital lobe, which is at the back of the brain. It's involved in interpreting visual information and also controls how you process shapes, colors, and also movement. You also have the temporal lobe, which is at the side of brain and controls short-term memory, speech, musical rhythm, and also controls sequencing, organizational skills, so everything around those types of movements. Then you have the cerebellum, and this helps you in terms of maintaining balance, position, coordination, as well as fine motor skills located towards the back of the brain, and it's near the brainstem. And if you were to damage the brainstem, you'd be dead. But yeah. Okay, so what's the difference between the brain of people who have epilepsy and the brain of people who don't have epilepsy? So people with epilepsy have a lower volume of the right thalamus, which sends out the sensory and motor signals. There's also reduced thickness in the motor cortex, and this controls the body's movement. So these reduced volumes and thickness are linked with a longer duration of epilepsy. Gosh actually discovered in July 2022 using diffusion MRI techniques to analyze how the different parts of the brain are connected with the brain of a child with and without epilepsy. So they compared the two, and they were able to understand that children which did have epilepsy had more wires connected in the brain, and these increased wires and connections made them more likely to have epileptic seizures. Next slide. Okay, so symptoms of epilepsy, these can vary depending on what type of the brain is involved in terms of different lobes and where the electrical impulses are coming from. But some common symptoms can be uncontrollable shaking or muscle jerking, having seizures, tonic seizures, so losing awareness, staring blankly. These seizures can affect their brain thought process and can also lead to a petit mal seizure, collapsing, drop seizures, strange sensation like a rising of anxiety, tingling the arm, or actually becoming stiff because the motor neurons actually tighten, and this can also cause your muscles to tighten and lead to motor seizures. Some triggers could be stress, disrupted sleep, alcohol use, or sudden withdrawal. Flashing lights, caffeine, or diphenhydrin, which is an ingredient used in sleeping pills. So most people with epilepsy are advised against using them. And these seizures can actually be produced randomly and suddenly based on the electrical signals, and they can often last from 30 seconds to around 2 minutes. So what causes epilepsy? So in around 70% of the cases, epilepsy, the cause is not known. However, some known causes can be genetic influences. One seizure which we definitely know is due to genetic influence is the juvenile myoclonic epilepsy, so JME for short. It's likely to have been inherited due to a mutation in the GABA gene. Brain infections such as encephalitis can also cause epilepsy. Any autoimmune diseases could trigger your immune system to attack your brain cells, and that could also again trigger epilepsy. And any developmental disorders such as birth abnormalities affecting the brain can also be a frequent cause of epilepsy. An example being cortical dysplasia. Okay, so there's four main types of seizures, but these seizures are often produced as bursts due to bursts of electricity in the brain and can be categorized again into four different types. So we have focal seizures, focal epilepsy, generalized epilepsy, focal and generalized combined epilepsy, and unknown epilepsy. Focal epilepsy only focuses around one target area in the brain and often begins with an area which have minor symptoms that the patient may not notice, such as altered feelings, so premonition. As the seizures progress, a mixture of motor and non-motor symptoms can be experienced. Generalized epilepsy often affects both the left and the right sides of the brain. Um, both of the right sides of the brain. This seizure can either be by motor or non-motor, and this is known as absence seizures, and it's usually during childhood, but can also affect adults. Then focal and generalized combined epilepsy. This is a mixture of both focal and generalized epilepsy. Having a mixture of both symptoms can be experienced. This is linked to Dravet syndrome, which is a rare lifelong form of epilepsy that is due to a mutation in the SCN1A gene. Unknown epilepsy, that's when the doctors can't isolate where the seizures originate, and they will diagnose unknown epilepsy. Seizures usually last between 1 to 3 minutes. If they last longer than 5 minutes, you can call emergency services. Okay, so the diagnosis of epilepsy. In order to be diagnosed with epilepsy, a person must experience 2 or more unprovoked seizures. Seizures can be caused by many stimulants, such as a head injury, toxins, tumors, and infections. So before diagnosing, doctors need to rule out all other possible causes of the seizures. After this, doctors can then determine which type of seizure it is through various tests, for example, an EEG, a CT, MRI, or most arguably just by taking the medical history to see maybe someone in their family previously has it. An EEG also measures electrical conductivity as well. Okay, so some treatments. So having treatments allows patients having treatments allows patients to reduce.
I think we're having a couple problems here. I'll just end this off then. So having treatment allows patients to reduce the frequency and severity of their seizures. Um, or in some cases, stop them entirely, so it will cure them. Um, Vagus nerve stimulation is a small electrical device placed under the skin of their chest, and it's attached to a nerve to change the electrical signals in a brain. So vagus nerves are the main nerves in the parasympathetic nervous system, which controls the involuntary actions of the body. I think Silver just joined. She might be able to continue.
Sorry, my internet just cut out.
Yeah, that's fine.
Okay, so vagus nerve stimulation is a small electrical device that's planted under the skin of their chest and attached to a nerve. This can change the electrical signals in the brain. The vagus nerve, these are also the main nerves in the parasympathetic nervous system, and they can control involuntary actions of the body. Some side effects, however, could include a hoarse voice, a sore throat, cough when the device is activated, deep brain stimulation. This is another treatment similar to vagal nerve stimulation, but the wire is actually connected directly to the brain instead of being connected under the skin of the chest. You can also take anti-epileptic drugs, so these can change the concentrations of different chemicals within the brain, for example, sodium, valproate, and carbamazepine. They are different types of AEDs, so the doctors must consider specific characteristics for each patient when prescribing. For example, sodium valproate is not prescribed to pregnant women or those trying to conceive because this drug can cause fetal valproate syndrome or FVS, which can affect baby's development. So they are also available in forms such as tablets, syrups, or capsules. Some common side effects can include headaches, drowsiness, a lack of energy, or hair loss. Some other non-drug ways can be a ketogenic diet. So this includes a low-carb and high-fat diet. It helps control seizures by changing the levels of chemicals in the bodies and was actually more commonly used before, but now AEDs are more preferred just because they are more manageable. And a surgery can also be used to remove sections as part of the brain where seizures are also triggered from, but those are in more extreme cases just because messing with the brain can lead to a lot of different issues. Okay, so some new treatments which are being developed can include LITT. So this is a new laser beam treatment which was actually released a few months ago by the NHS, and this procedure is available all over England. From June, it's been offered in the Walton Centre in Liverpool and also KCL in London, in a specialist national hub. These are fiber optic laser therapy, which allows part of the brain and this causes the seizures to actually be targeted, allowing for treatment to not involve invasive surgery. A tiny hole within the width of 1.5 millimeters is drilled at the top of the skull to insert the fiber optic laser, which will reach and destroy the epilepsy, causing brain tissue by heating it up. MRI scans are also used to ensure healthy parts of the brain are unharmed. As I said, messing with the brain can lead to a lot of different issues, as you guys saw with how all the different lobes interact together. So the wound can actually heal quick enough that the patient can go home after receiving just 24 hours of treatment, which is really fun when I get patients home so they can get better. So researching epilepsy. Okay. So, despite the disease being quite common, doctors are still attempting to find out more about this chronic disorder. One example was actually a study done by Stanford University, which involves mapping the brain to decipher where epilepsy stems from in order to produce a more effective approach to treatment. Ivan Salatis, PhD, found that a previously overlooked region of the hippocampus known as the fascicular I don't know if I said that right, but it appears to be involved in stimulating seizures. Neurons in the posterior region of the hippocampus were active during seizures in mice, and these neurons were fed proteins which were capable of shutting down activity when exposed to blue light. And when researchers shine blue light directly into we're going to call it FC, the duration of the seizure significantly decreased. So he therefore concluded that patients with drug-resistant epilepsy should have electrodes placed in the FC as part of the surgery planning process, as the current positioning of the electrodes miss this region of the brain. But yeah, thank you guys for coming.
Thank you so much, Silver. I'll just send the meeting link, like the attendance form. Please fill that out. And yeah, thank you very much for joining. We hope to see you next week as well.